Dr. Rishikesh, managing residual esotropia.
Rohit sir, you are leaving. I have just one question for you. Actually, I'm sorry for that. I have done this fixation of the medial fixation of the globe in case of a third nerve palsy. Somehow, couple of times in the same case, the suture, the knot becomes loosens up over time. As a result of which, there is a exodrift. Have you?
So like I said that earlier, that rig surgery was this it'll loosen up because the periosteum over time will get lifted. We did an imaging to see the tensile strength will reduce. So that takes a year. So if you do a non-absorbable, you have to use ethibond or you don't use.
Yeah, we use non-absorbable only. Yeah.
So it usually the tensile strength is there for at least 6-8 months to a year, and by that time the fibrosis has happened. I mean, when we went in back again in this case, huge amount of fibrosis. So there are a lot of fibrous strands. So the advantage, the aim is that you slightly overcorrect because you will get this lift and that's drift. So we do about 5 to 10 degree intraoperatively of overcorrection so that you catch that drift. That drift will happen, but you catch for that.
And what needle do you use?
So the needle that comes with the ethibond, I just 50 ethibond.
Make it straight.
No, curve it more.
More. Oh.
So that you can, there is very small space. So we use the pre-caruncular technique. So you have a very small space, but that's why you can just, with a just single twist, you're able to get it out of the periosteum.
I use the 5-0 tacron.
Yeah.
And I anchor it to the medial.
Yeah, that is why.
Medial palpable.
Palpable. I also did with the.
So it's quicker surgery.
Yeah, that is true.
One more question. All your augmentations are to the sclera, like SRD and all that. Do you just tie with the muscle?
No, I never tie with the muscle. Always.
Sclera.
Always.
In the case of Nisha.
So we haven't found any significant torsional change on fundus after doing any SRTs or any transmission. We've done IRTs also.
Sclera do you take?
Sorry?
Suppose you have to anchor the medial to the periosteum. Where do you take the scleral line?
No, she is asking about posterior fixation suture.
So from the periosteum, right adjacent to the medial rectus.
Okay. Just
So there.
adjacent
So
to
two
it.
separate sutures, just like do for a section. Not through the tendon, through the sclera adjacent to the muscle.
Sometimes sclera don't have it.
I think we'll carry the discussion later on.
Okay, actually, he is leaving, so
Yes.
he was. Okay, thank you, sir. Thank you, Dr. Shubhangi ma'am and scientific committee for this opportunity. My talk is on managing residual esotropia. So I'll just give a background about esotropia. We have already covered exotropia and paralytic strabismus, and also vertical squint. So esotropia is associated with amblyopia and loss of binocular vision compared to exotropes, as everybody is aware. That's why significant cases of esotropia we tend to operate earlier in life compared to the exotropes, and many of the times it is a constant ESO, unlike exo, which happens to be intermittent in between. So the commonest surgery for ESO is medial rectus recession, either unilateral or bilateral, depending upon the angle of deviation. In spite of being one of the commonest strabismus surgery, we don't have any consensus as to the type of surgery or the surgical dose. Every surgeon has its have their own algorithms or norms for doing this particular procedure. According to literature, what literature you follow, the chances of undercorrection have been reported to be around 22 to 40%. So the surgical options for esotropia are medial rectus recession, most common is the bilateral one, or unilateral recess resect. Sometimes depending upon the angle of the esotropia, you can do a 3 muscle surgery also. Usually esotropia, the result, especially the cosmetic results, are are very gratifying in children as well as in adults, but there are chances of residual esotropia, especially, I'm going to talk in the early post-operative period. There are various risk factors which have been associated with residual ESO. One is the angle of deviation. It has been found that if the angle is more pre-operatively, then the chances of having a residual ESO are more. Also, the age of the patient, higher the age, it's a long-standing esotropia, then the tone of the muscle changes, as a result of which the post-operative outcome might be slightly more unpredictable compared to what you will get in a earlier age group. The refractive error, hyperopia, is associated more with there are increased chances of residual ESO compared to an emetrope or even a myopic patient. sometimes if in the in earlier age of life, if the surgeon misses out on inferior oblique overaction, he might end up treat only the esotropia, but the inferior oblique overaction can lead to a recurrence, or it can have a residual esotropia later on, and presence of even a latent nystagmus has been associated with chances of residual esotropia. So if there is a residual esotropia, what are the surgical options you have? I mean, lateral rectus resection is the first commonest surgery. You can do a medial rectus re-resection with or without adjustable. Botulinum toxin has also been reported, and also marginal myotomy of the recessed medial rectus muscle. The commonest surgery which is done is lateral rectus resection for residual esotropia. The chances of due to the chances of overcorrection, the surgical dose in these cases, I mean, if you are repeating the surgery, is usually Oh, I'm sorry. I mean, this is it has to be resection there. The chances, if it is due to chances of overcorrection, the surgical dose is usually reduced by around 0.5 millimeters. Up to 20 prism diopters, you can get away with a single muscle surgery, but beyond that, you have to do a 2 muscle surgery. The maximum resection which you can do is around 8 millimeters. The advantage is that it is surgically less challenging. It's like operating a new case because you are operating a fresh muscle, and hence the chances are much more predictable. However, the disadvantage is if you still have a residual ESO after doing all the 4 muscles, then there are very few surgical options you are left with. So, I mean, this is one of the case in which we did a lateral rectus resection. Plication, I think we already discussed. I have not done plication for residual esotropia, but I have done 3 or 4 plications otherwise, and I think the results are quite encouraging. You can do the same even in these cases. Resection is a pretty straightforward procedure. Most of us are doing it. So, coming to the medial rectus re-resection, the medial rectus resection, if the previous resection has been 5 millimeters or less, you can further do the re-resection, and it can be done on adjustable. If it is around 16 prism diopters of ESO, residual ESO left, then you can get away with doing only one re-resection. But beyond that, and beyond 20 prism diopters, it's better to do the re-resection for both the sides. The advantage is that you are touching the already resected, operated muscle. So even if you have a residual ESO, you can have the lateral rectus later on for surgical use. And also the disadvantage is that I mean, you are operating on the already operated muscle, so the chances of the procedure becomes less predictable, and also the chances of overcorrection or adduction limitation are there if you are done much more recession than what you are supposed to do. This is one of the case which I mean, one of my colleagues had operated. Actually, he had asked my opinion for this case, and just based upon the photographs which he shared with me. So ideally, I mean, you better to evaluate first and then decide, not based upon photographs actually. So when I found and I opened the eye, I found that the recession previously done was only around 3 millimeters. So 3 millimeters of bilateral recession perhaps is not going to give you the desired result if the angle is around 25 prism diopters of ESO. So because I was operating in early post-operative period, the fibrosis and related complications were not there. But in a late post-operative period, the fibrosis develops, chances of bleeding, and tracking the muscle also becomes difficult at times. But once you have hooked the muscle properly, ensure that all the muscle fibers are properly hooked and engaged into the 6-0 vicryl suture. The rest of the procedure becomes straightforward. What you need to remember is that if you are doing a re-recession for 1 millimeter of medial rectus re-recession, the correction might be more. So it will be around 6 to 7 prism diopters, unlike for a routine recession. But for lateral rectus resection, you will get around 2.5 to 3 prism diopters per millimeter of correction. Rajavi et al., that was a study done in Iran, and they found that there was, as far as the alignment outcome, even the long-term alignment outcomes for both the procedure was almost the same. There was no statistical significant difference between lateral rectus resection versus medial rectus re-recession in a residual esotropia. So these are the commonly done surgeries for residual ESO. This was the case I was talking about. I mean, the first 2 pictures, I mean, these 2 pictures are the pre-operative. The third one is the first post-op, and after the re-recession part, I did a bilateral re-recession in order to get ortho in this case. So marginal myotomy, I don't have personal experience, but this is one procedure which has been described, that cutting a part of the recessed muscle of the medial rectus. It is done especially if there is already a scleral thinning and passing the sutures through the sclera becomes difficult. The disadvantage is that it is surgically challenging and the results are not predictable. Usually, in a case of residual ESO, marginal myotomy of a medial rectus is combined with resection of the lateral rectus. The botulinum toxin is one of the procedure which has been described in literature. Botulinum toxin around 3.5 to 5 units is injected into the already recessed medial rectus. The long-term follow-up of around 34 months or more has found satisfactory result only in 50% of cases. That's why for a residual ESO, this is still not a very popular procedure. So with this, I want to conclude by saying that residual ESO is the commonest challenge after surgery for comitant esotropia. Most common surgery for residual ESO is lateral rectus resection, and as per the studies, there is no significant difference in the alignment outcome after medial lateral rectus resection versus medial rectus re-recession. Thank you.
Thank you, Rishikesh. How often do you use adjustable sutures in re-surgeries?
Not very common, ma'am. Actually, if because the nomograms even for resurgery, especially for residual ESO, are there. So I have not done around 2 or 3 cases only on adjustable, not much. Okay. But otherwise, I do it without.
Because sometimes again we are doing it for residual, it goes into exo.
Yeah, that's what
So.
I wanted to ask, how early do you intervene when you have a residual ESO?
I actually counsel the patient for surgery as early as possible, because if we don't operate early, the premise of the first surgery itself is defeated, because if it's a residual ESO.
I would beg to differ. I think if you have, I would wait a little more time, because if you aim to keep him in ortho, and especially if the patient is amblyopic, there's a very high chance that you go into consecutive extension.
No, in case of amblyopia, it's different. But if it's not amblyopia, both eyes, the patient is the vision is good, I will try to get the alignment as early as possible.
Still 6 to 8 weeks of we have to wait that much for
Yeah, I wait for
3 months.
Most
Yes.
of the patients in who have had an ortho in the first sitting, they eventually
Go into exo, yeah.
because they are inevitably amblyopic. In ET patients, you get a good cosmetic alignment, but the functional outcome is not so good. So you have to remember that they are all going to come back to you with large XTs later on. So I would prefer to leave them about 5 to 10 prisms ET and tell them that eventually their eyes will become straight.
No, especially in adults, like the base, I don't aim for ortho after esotropia surgery. A bit of ESO, because it might ease out and become ortho later on. Because if you get ortho in the early post-operative period after ESO, they drift into an exo later on.
Because
That's right.
recently 2 of my patients who had the esotropia surgery by me in their childhood came. I now did their lateral rectus resections, and both of them have gone into
Exo treatment.
somewhat exo. It's
The minute the eyes are straight, they stop wearing glasses. They stop opening.
it's now early post-op, but we'll have to see what to be
That's
done.
why we treat
normally.
amblyopia first, because if we get the alignment right,
These
they
are
won't do
now
the alignment
adults.
amblyopia treatment at all.
They are now adults.
It all
good
depends
vision.
upon what case we are looking at. Is it an adult or a child? Do they have amblyopia or not? Do they have hypermetropia or not? And also the last one, which is very important, is if they have any cortical visual impairment. If these patients, if you overcorrect or just correct, they are 100% going to go into XT. I would definitely wait for 3 to 4 months before we really go into take, unless there are some sensory esotropes. Adulthood, they just come for marriage, because esotropia looks worse than little bit of exotropia. So there probably you can go in early, especially in a sensory esotropia in an adult. Because infantile esotropia, if you do a surgery in an adult, again they can have a very high chance of ARC. This is a dangerous population. You will have abnormal retinal correspondence, so they will have diplopia also. So it all depends. We can't put in one rule for everybody, but it depends upon multiple factors.
Especially for resurgeries, it's very difficult to put rules actually.
Thanks,
Exactly.
Rishi. And again, we are changing the sequence, but yes.
In MLabs, usually we would select a single eye RNR, but when we are dealing with children, like supposing the child is 6 to 7 years and you are trying to treat amblyopia by correcting this, like strabismic amblyopia, then what would you suggest? Single eye or either? Or by RNR?
If there is amblyopia,
Yeah, it is a strong preference for one eye, then RNR is a good
whatever,
procedure.
Like, even if the age is 6.
Yes.
should not be a problem. And if you want to do it even bilateral, it's not a
Yes,
problem if the
yeah.
difference is very minimal. Because if you are, again, it looks like if it is 60 prism diopters or so, probably rather than doing a very large resection where it will cause a little bit of inophthalmos, probably you can balance it. But if it is something like 30 or 40, even that inophthalmos gets better. It's better to do a recess resect.
And also the parents have this big
Yes.
concern that you're operating the
Good
eye.
eye,
So it's
huh.
always better to tell them I'm going to do the bad eye.
Yeah, but that concern, I think, if you explain to
can,
the
huh, we
patient,
can explain
nothing
and-
happens.
But I think psychologically they're more prepared to do the other eye.
Yeah.
Correct.
Explain to them, even in adults.
Yes.
If they're more prepared to do
They don't want to touch the normal
Yes.
eye.
Since there is no big advantage, you can always do a recess resect.
So-
Problem is that after life, if they have a narrow valvular budget,
I know. That's why large angle,
Large angle
I
we
try
don't.
not to do a
40,
recess
45
resect.
we can get away.
And also what I've noted is like in children, when you do a recess resect, you get a greater response than adults. So if you have 60 prisms also, even a
Yes.
normal nomogram will give you a larger correction than an adult. So don't hurry and do the third muscle. Just do the RNR and do it.
Yeah, the
So-
question is not about third muscle. Question is whether to do bilateral
Or
or
recess
two muscles.
resect.
So infant no need to do 3 muscles.
No.
Unless it is 75 or so, maybe beyond 70,
Seven.
where we might have to do it. Otherwise, no need.
Most of the
Because
ESOs get
we
corrected
do
with two
get
muscles
more
only.
response in a child as compared to the adults per millimeter.